is a really a very left main trifurcation case, right?
Trifurcation.
Yeah.
Not trifurcation. Actually, it is. I don't know how to I explain. It is almost all branches are blocked, right? So our
Yeah.
primary target to treat left main bifurcation or trifurcation. What is your initial strategy?
No, my plan is actually to put 3 wires into 3 branches. That is the first and foremost thing. To put a wire into the ramus, then to the circumflex. The most complicated wiring will be in the circumflex. That is what is my thinking. And then LED. LED actually, if you look at the angiogram, can you just show the angiogram? Next shot. This actually even a mid and distal LED also diseased. So when you do an angioplasty to the LED alone, if you consider, you have a proximal LED, osteoproximal LED disease, a mid and distal LED disease. If you look at the LMCA, distal LMCA is actually having a disease. The ramus, if you look at the ramus, the osteoproximal ramus is actually having a minor plaque. But if you go distally, the ramus divides into 2 branches. One of the major branch has a good disease, and the other one is also having disease. And if you look at the next projection of the ariocaudal, no, ariocaudal. When you look at the ariocaudal, there are 2 branches of the ramus. The major branch is actually having a less disease, and the other one is a smaller branch. So even if I do something, I will be preferring to do something to the major branches of the ramus. So when you look at the circumflex, it is actually like an almost like a 90-degree angle, and it is when we do intervention, I will prefer to do a balloon angioplasty, initially a balloon inflation to the ramus, to the circ ostium, LED ostium, then LED mid, and then do an imaging of the system. And preferably, I can avoid putting a stent into the ramus. I will avoid it, but definitely I will put a stent into the circumflex ostium and the LED ostium, where I will manage with a DK crush technique, keeping a wire into the ramus. If there is no problem, you can actually put a final balloon inflation with the 3 balloons together, a 3 balloon or 3 or 3.5 balloon into the LED, probably a 3 balloon into the circumflex, and a 2.5 balloon or 2.25 balloon into the ramus. That will be my strategy in this case. But any discussion, actually, I just put a, can you just show the first shot today? This was the first shot. Second, next, we actually initially tried to put a wire directly into the ramus. The wire gone easily without any difficulty. Next, we are actually trying to put in the circumflex, because the circumflex origin I have to see properly. That was one of the toughest thing. That is why I put decided. Circumflex wire also gone easily. Then next, is LED wiring. Yeah? That's a long, we have taken the wire. The wire did not go properly. Then we have taken the wire out. See the wire gone. That an angle is there. Wire gone easily. Not with any difficulty so far. This is the situation we are. So we just put 3 wires. Now, after you are all coming only, I wanted to do the procedure. That is what is my plan.
So
Any different opinion?
So your upfront strategy is go for double stent strategy, especially in DK crush technique.
DK crush for the LED and circumflex, and ramus I keep a wire. But before that, I will do a POBA to the mid part of the ramus. That probably I will do a 1.5 or a 2 millimeter balloon and dilate that part and just keep it there. If the vessel is opened up, I can just leave the stent there, because I don't want to have 3 metal strut in the LMCA territory to make it more complicated. And the people actually everybody prefer to have a single stent strategy, but in this case, impossible to have a single stent strategy, because the side branch is a major vessel and you have a more than 8 millimeters of disease, 7 millimeters of disease, and that is significant disease by angiogram. So whatever the procedure, we decided to do an OCT in this case because we will actually show the OCT with half saline and half contrast together because the creatinine was 1.3. It is not a big issue, but even then I wanted to use less contrast. So this all wiring was done without contrast. Especially the only part which I used a wire was the contrast was that when I just passed the wire into the LED. Otherwise, I did not do any injections with contrast for passing the wire. So I was actually preserving the contrast for doing the OCT.
So thank you, Dr. Pratap. I am Dr.
Please,
Ashok
please.
Datto. So this is a really difficult case. There is lesion in the RCAPDA, trifurcation lesion. The one advantage you will get here, that is not true ramus. That is actually high OM. That is the advantage that if you do the decay crash, LAD and LCX, chance of occlusion of the high OM is less likely and subsequent wiring will not be so difficult. But if it is a true ramus, after doing the decay crash in the LAD and LCX, it will be very much difficult to get the access to the ramus because it will be crushed by the two stents. So high OM, that is on advantage. The decay crash is relatively.
But actually just show the angiogram. I have some objection there. Please stop it. Just go back. But if you look at it, it's actually a ramus only because it was
Yes,
not
in this
originating
view,
from the
but in
circumflex.
other view, it looks like high ramus, yeah? High
That
OM,
is
yeah?
actually no, that is actually, I appreciate your comments. But when you look at the ramus, always ramus to be defined by keeping the vessel in the elevocaudal to see the trifurcation properly. This looked like a ramus. That is to me, even if it is a high OM1, even then it should be considered as a trifurcation only. But decay crash actually you can do otherwise, having a 3-stent strategy, but I don't want to make it more complicated. I think that is what is my thinking. If you have a different opinion, I can just go ahead with that also. Any other opinion?
So you are considering right now imaging, right? OCT.
No, we are actually just any imaging in this case, you require a balloon inflation, then only you can do imaging. Because I don't think the imaging catheter will be taken either into the circumflex or into the ramus or into the LAD without a balloon dilatation. If it is, whether it is OCT or it is 4-5. Or
I
it is,
agree with you
I-
because there's a 3-strand is impossible to keep in the left main. I agree with you if you go for the LAD. If there's a pinching of the ramus, you can do KBI and get away with it.
deflate. I'm actually balloon dilating the ramus origin by a 2mm balloon. 212 balloon I have taken. We went up to 8 atmosphere distally and 10 atmosphere proximally because it is a 2mm balloon deflate. We are actually not bothered about that much dissection. Now I'll take the same balloon into the circumflex and a pre-dilate first. And to understand the feeling, if there is a very, very tough situation, I may go even with a cutting balloon in the ostial part of the circumflex and ostial LAD. My strategy in LMCA, I always prefer to take a cutting balloon in the ostial circ and ostial LAD in every LMCA which I have done. So we are actually doing a randomized study for the randomized means actually a single center randomized study for the OCT guided LMCA intervention. We have completed 52 patients. And actually our aim was to complete 100 cases in the last year itself. But because of the corona and all, we could not get this case load that much. So we completed 52 cases so far, not even a single event and not even a single problem we raised by the LMCA bifurcation stenting by OCT.
So have
So
you
this
done
actually
any imaging?
No, so far not image. No, we definitely will do an imaging in all the case of LMCA, but I'm telling we do an OCT. This
Yes,
we are
yes.
doing a pre-dilatation. Go ahead. We are taking a 2mm balloon, 10, 11, 12, 13, 14, high pressure. 1518.
So what about the hemodynamics of the patient and what guide
BP
catheter are you using? Is it 7 French?
It is a
EBU, yeah?
7 French EBU catheter. Hemodynamics actually 160 by 80 BP now, and the heart rate is 67. Definitely there is ECG showing ST depression in the lead one, which is shown in the monitor here. If you can show the monitor, very happy.
There are
Can you just
two
see
other
the same
lesion,
balloon?
one in the proximal part of the LAD and mid LAD. What is your plan to do the tackle the lesion?
we
Do you
are
want
always,
to tackle
no,
after
definitely
doing
do
the
it.
left main, or before doing the left main, you like to treat the mid LAD?
No, our aim is actually, we may do a pre-dilatation beforehand, but I don't want to do an intervention beforehand. We actually
Yes.
wanted to do an intervention after doing the LMC only. Any different strategy anybody will apply, and if we can, I can hear it, because I thought
So-
it is an interesting case of discussion.
So there is no question about the two-stent upfront two-stent strategy that should be applied in these circumstances. No way single stent strategy would be helpful here. Second, which strategy do you like to adapt here? DK crash or tap or pull out?
No,
Because
definitely it is.
No, yes, that is the option I was talking about. That is not the good option in this case. But anyhow, DK crash is a very good option in such circumstances.
We actually do only two techniques in all LMCA bifurcation. Either it is a DK crush or a mini crush. That is only two techniques we adopt. Tap stenting and the culotte, actually, I don't prefer to use a culotte. Culotte is the simplest of the technique I will prefer. And in DK crush, we usually LAD. DK crush actually will be the ideal technique in this case, because since it is a live case, if the time permits, I will only go for the DK crush. Otherwise, I wanted to finish in that stipulated time of 1 hour, because you have 2-3 lectures also, I know that. So
Do you think that
if possible,
this is the ACS case, non-STEMI case, so mini crash can make the procedure more simpler?
it is actually not an NSTEMI. Actually, the patient was admitted with NSTEMI earlier, and then we did an angiogram, and then we advised for a CABG. They were not willing, and then we thought actually this, since Assam called me, I thought, okay, I was initially planning for a CTO intervention. Then I thought for this procedure, better to have a different intervention by me, because people always see my CTOs, nobody see my other intervention. I thought it's a chance for showing that. I have taken the OCT catheter. I don't want to take as deep as possible because I did not do a dilatation there. My aim is to understand what is the size of the LMCS stent to be used, what is the plaque morphology, to make them understand. Okay. So this is actually a okay, can we go? Sound കുറയ്ക്കാൻ പറ്റില്ല, ഇവിടെ കുറയ്ക്കാൻ പറ. Okay, go ahead, ready. ശരി. No flow. No, it is safe, unsafe.
Did you predilate the mid LED lesion?
No, we did not do that. We could not get an image of the OCT.
Yes.
So just give me a 3 millimeter balloon. 2 millimeter balloon. There are 2 millimeter balloon. Can you give me? I will dilate the distal also. If that is because the distal dilatation is not there. Whatever we got, can you show? Calcium is there. ഒരു വയറ് പോയാൽ പറ്റും അയ്യോളെ ഞാൻ വയറെടുത്ത് കഴിഞ്ഞാൽ പ്രത്യേകം
So
Oh,
70 years old, severe TBD, definitively very high risk patient with left main trifurcation lesion.
full don't dilate,
I think a bit more distal.
deflate.
Yes, at this level. Yeah.
Deflate.
It's
Give me a 3 millimeter balloon, proximal. 3. Contrast. Adura kitile, then I will go for IVUS. Actually, now we are going to dilate with a 3 millimeter balloon, proximal LAD and proximal circumflex. Then we do an OCT and just see. OCT actually, whatever we have seen with the small proximal part, we saw a calcified nodule. So I was thinking that since it is a calcified nodule I have seen, I just don't want to go for IVUS because calcified nodule can be better seen by. Can you just keep the catheter a little away? Catheter away. Okay. Go dilate. 15, 18, 20. We actually 100% sure that the lady will be proximally
yes.
3.5 SL.
So this is 3012
I-
balloon, yeah?
3 because I don't want to take a 3.5 because without clearly understanding what is the size of the vessel, because 3O will be ideally good. If the 3O also not producing a good image by OCT, I will actually take an IVUS and show the image. This one. So now we do pre-dilatation of the circumflex. If any of you actually, if you are doing this case, how do you approach this case?
This is the same balloon with which you dilated the left main to LAD, yeah, 3012.
Yeah.
There is a angulation at the LCX origin, so
So dilate 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Deflate. It's backing up. I know this, and this will be the toughest situation for me all the time. Go. 10, 11, 12, 13, 14. Deflate. No. Gone down. Now
yes.
inflate. 11, 12, 13, 14, 15, 18. So this is actually one way of doing. If there is a problem of actually when your balloon is not deflate. When your balloon is not going, you dilate whatever is possible in that proximal part. Then you go slowly and then cross it. This is actually applied for even for the CTO intervention also. Okay. So far the hemodynamics so far is very good. Still maintaining the BP very well. Now I decided to take an OCT. No, LED. I hope this OCT will work. Manu,
Patient don't
are you
have any
ready?
chest pain, yeah, don't have any symptoms. Yeah?
No symptoms as actually if you look at the ECG looks much better now. Probably the
Hemodynamics
balloon
is quite
dilatation.
good.
Yeah, very good. 150/80 BP. ECG looks now the ST depression is totally gone. These type of cases actually this angulation and image catheter may not go properly. Usually sometimes I do in these cases when you can take a guideline and take the image catheter down. But this is a catheter. You can see in OCT there are 3 markers. The distal marker is not the point. The second marker to the first marker. Now 1, 2, 3 markers. The distalmost marker is not the point of discussion. The second and the first marker will be the 2 discussions point. And now we are actually purging. Can you read? Ready? Catheter is engaged very well. Lay. Already I am ready. Ready. We got a decent image. Actually, the OCT technician was very much worried. If I don't get a decent image, I will just switch over to IVOS.
That's on the
We are going to.
So pre-PC assessment, OCT assessment is based on MLD to assess the lesion morphology. That's the initial aspect. Then to stent sizing based on the lesion length and the reference vessel diameter. So if you look at the morphology of the lesion, here you can see a significant fibrous lesion with the concentric deep calcification also, almost circumferential calcification. And coming this distal part of the lesion. Okay, mainly fiber, there's a fibrous lesion. You can see it's a signal rich intensity. And with the deep chunk of calcification, that is limited to less than 180 quadrant. So can you measure the calcium thickness, calcium length, and the show the?
Sharath, can you explain the calcium thickness?
You show the calcium thickness that.
No. You just go to the distalmost part. No, that is actually a lesion part. Go distalmost, distal, and that should be taken. No. That should be taken as a point where decent vessel, but even then there is a calcium chunk there. Come back, very tight disease there. Correct?
Yeah, this is a fibrous lesion. Fibrous and calcific, deep calcification.
They are calcified, yeah.
So that means lesion modification requires some modified balloons like cutting balloon.
Okay.
1, 2, 3, 1. So
This is which
proximally
part
it
of
is
the LED?
about
Part of the
3.5
LED?
millimeter, distally 2.75 like this, yeah.
Mid segment they show the lumen diameter or EL to EL diameter. EL, yeah, you cannot clearly see the EL to EL here, but measure the lumen. It's almost 4 millimeters.
4 millimeter vessel.
Approximately.
Approximately 4 millimeter. That is actually the dissection created. That is the subcosting.
Yeah.
That's the osteal LED, yeah.
So can
Dissection
you see
at
the
costal LED, yeah.
stop?
They show the ostium part, ostial LED.
Can you show this ramus as well as the sub?
So trifurcation.
Almost coming together. It indicates it's a trifurcation because you can see that. Just go see from the proximal LED. There are 2 wires coming together. Now you can see the 2 wires coming down. And stop there. Stop. Can you show the 2 wires?
Yes.
See these 2 wires. So that indicates, and if you go probably a little more distally, see it is coming. This is actually the tight disease of the osteoproximal ostial LAD, then just come proximal. There are two branches coming together, and we could not see the. Can you just bring a bifurcation and angle and see? See the wire you can see now. The wire you can see. One wire you can see very well. That is actually the circ wire, probably.
That
This is the circ wire.
The other wire actually is an image underlying that. Ramus wire. So probably these three wires cannot be seen together. Two wires actually, this projection, and let's just go through the LMC. LMC, we created some dissection there. Just go proximal.
to show the LMC diameter.
That is because this is actually not having significant disease there, but you can see the plaque is very good. Just go.
Weird.
The EL to EL.
So almost 4.5
4 point.
LMCA.
To the proximal LAD. Before that, we really requires
Lengths.
balloon, the preparation of the vessel very well, preferably by cutting balloon, because the distal to the circumflex, the distal to the, can you just see the measurement, whatever is measured? Yeah, that part to that part. Whatever we got. No, can you see the septum in between? Septal artery. Probably that is the septal artery. Can you just, everybody can see the septal artery? That's a major vessel. So the septal artery, yeah. So that much part, definitely we can use a 4 millimeter stent, no doubt about it. And 24. Oh, if you take the total, 27 millimeters. We have to take a 4 into 28 millimeter stent LMCA, no doubt about it. And circumflex, I think we have to take, I don't know whether, can we get an OCT imaging is difficult. We'll take, try, circ. We have taken the OCT
Well,
circumflex now.
wait.
Just can you do fast?
Side port port.
Side port perch. Okay.
Sini. Injection. So.
You got it?
Yeah.
Got.
Naturally. Again, the circumflex lesion morphology is also basically fibrocalcific lesion, but calcium limited to less than 180-degree quadrants. And already the lesion has been dilated, so you can see a lot of dissections in the osteoproximal circumflex.
What
Now,
is the circumflex area? Size.
Just sizing, just show the diameter,
3.5.
reference vessel. For selecting the size, ideally you have to take an EL to L. If EL to L is not visible, you can take even a lumen is also sufficient. Maximum is 3.23. the lumen diameter. So that makes you can upsize by 0.25. So you can take a 3.5 stent in circumflex.
So 3.5 per stent in the circumflex, even if you wanted to take a 4.5 stent LMC is possible.
Possible.
3.56. Now we are going to take a cutting balloon into the LAD first, because circ, I think it is crossable. 3.5 taken. എങ്ങനെ മനസ്സിലാവില്ല? How many people will use a cutting balloon actually in these type of cases? After seeing imaging, we take a Wolverine cutting balloon 3.5 into 6 millimeter. You can take a 10 millimeter, because I took a 6 basically because I want to take the same cutting balloon to the LAD also, circ also. Go, inflate. 11, 12. People actually take only 6 and you have to go very slowly, but I've taken a 12. Go. 13, 14, deflate. Give me the same to the circumflex. We'll take a, what is the length of the stent to use in circ? We'll just go fast. You take a 15 millimeter. Madhya. Circuit distally is looking like 3 only, so we are going to take only 3 stent to the circumflex. The heart rate is low. Cancer. Brady. BP is okay, BP is okay, BP is okay.
So hemodynamics.
Deflate the balloon.
Brady,
Basically, you know, when you get a
so. The same balloon you are taking to the LCX also, yeah? But the patient, I think, heart rate is going down, yeah?
give me a 3 millimeter cutting balloon. Flow is less.
There is slow play in the all 3 systems.
Rushing balloon 3.5 എടുക്കാൻ പറയൂ.
And Dr. Pratap, I am Professor Mir Jamal.
Yeah, sir, please.
Have you checked the SCT?
No,
SCT?
no. Not checked so far, because we have given heparin 10,000
But-
because the time is not that much, you know.
Time is 30, 40 minutes already passed, yeah?
Due to slow flow. What is the-
Most likely lot of predilation, cutting balloon is used, so that might be the reason for
reason?
bradycardia.
That's right. Distal embolization.
Yes.
Go. inflate 10, 11, 12, 13, 14, deflate.
First
So
So
class.
deflate, you know,
Yes,
you want-
so for the juniors, for every case, bed preparation is very much
Mm.
important.
go,
Without proper bed preparation, stenting may be
Deflate.
harmful to the patient. So
deflate.
this is why
You know,
he
this
is
one,
repeated
Go.
pre-dilatation. First with Theo balloon,
Deflate.
now cutting balloon. He's doing pre-dilatation to the
Go.
LED
No, 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 I
ostium.
used only cutting balloon.
No, for
No
the
other
younger
balloon, only
ones, for the younger ones,
Yeah, yeah.
he is telling.
Go, go.
Yes, I am telling for the youngers, those, there are some fellows and some junior are here.
Even sometimes, we people, senior people, dilated with 2.5 millimeter or 2 millimeter.
Yeah, sometimes we are happy with.
Did not look
2.5,
very
yeah.
carefully, and when given the stand, then it was found that dog boning effect of
Yes.
the stand
So subsequent post dilatation
Ah,
and stent
becomes very much-
expansion become very much difficult.
very much difficult, and sometimes even fail.
ഈ ചെറുക്കനെ വിളിച്ചാലുള്ള കുഴപ്പം. കുഴപ്പം. അത് വേറെ ഒരു കുഴപ്പമില്ല.
Still there is slow
The section
flow.
is there. So can you just give me a
All the three-
20, right? 320 fast. Stent,
So-
stent. Stent to the circumflex down. 318 Dhari. 318 stent. എടുത്തോ 3.5 എടുത്തോ പറഞ്ഞിട്ട് 12.
So this is
Balloon fast.
312 in the LCX, yeah?
318 because it was 15 millimeters.
Sorry,
We
18,
got.
18, yeah.
So we have taken an 18 because we have to crush 1 millimeter there.
Yes,
So. And probably we don't know how much dissection distally is there. So we did not do any imaging after that. So we decided to take an 18
Bigger
millimeters.
size,
so
yes.
still your plan is to do the DK crash, yeah?
mini crush.
Now mini crush is the ideal situation because we have to finish fast, you know.
Yes.
Yes,
small
yes,
check.
that is important.
Yes.
That is very important. You have to do the
Go,
very
go.
fast because already there is lot of slow flow.
11, 12, 13, 14,
A
deflate.
bit more in the left main. A bit more in the left main.
15, 18, 20, deflate.
Flaring of the ostial part.
We actually dilated in the proximal part because we have to go high pressure to open the stent strut very well.
Yes.
Can I get the balloon inflation of the circ? The crush. It's okay. That wire is okay. Just crush balloon, inflate. 15, deflate. Some people actually take the balloon out, wire out. I don't take the wire out.
Short
Go,
size
go.
bit,
Inflate.
you are using to
This is
crash the LCX.
3.5 because we are
Yeah.
actually going to take a stand of 4 millimeter minimum. Ideally, to be speaking, we have to take a 4 millimeter balloon.
Meaning that you always want to crush with a bit higher size balloon with higher
Yes.
pressure.
That's an ideal one.
Yes.
So balloon, if it is not appropriately sized, the stent will not be crushed well.
That's it. Will not be crushed adequately.
Small check, small. No, I think we have to go for the mini crush and finish it off. We will take this wire out. Take the mini crush. 428. BP is well maintained now.
Flow is
നേരത്തെ
also
പോയിട്ട് വരൂടെ?
improved.
BP improved very well. So, BP ഒന്ന് check ചെയ്ത് ആദ്യം BP. Okay. കണത്താണോ? കൊടുത്തോ. Flush. You have given a bolus of eftifibatide now. And you take a Nicoran also. You have taken a 4 into 28 stent.
So that is the 4 into 28.
28, 4 into 28. Again, all the stents are science expedition. I did not tell the name of the stent. No, we will take the wire. Just show shallow cranial to see the ostium. We are going to put the stent from the ostium.
Yes.
Shallow
So
cranial,
cranial is the
20-20 angle,
basic
20-20.
Allocranial.
So where in the LCX you kept it like this, yeah?
No, no, wire is actually in the ramus only, not in the circumflex. Circumflex wire is
LCX
already taken out.
That is in the ramus.
Whatever. No. Small check, small.
Yes.
Okay, go.
This is perfect position, yeah.
11, 12. Fluoro, stop. Epicranial, fast.
For the younger colleagues, you see, to place the ostial LM, it is almost always allocranial view is essential. And
15, 18,
beyond
20.
this, we
Deflate.
can keep a floating wire, Caspal wire, what yesterday Professor Fazilatunnisa Malik has shown.
Yes, that is also important too.
Very important.
Yes.
Sometimes we miss the step.
So,
If carefully see, then another stent is required.
so pull back and high
22.
pressure, how
Yes.
much your,
And it is also
18.
commonly used, pull back the same stand balloon and going up to 24, 26, 28 atmosphere.
Arroyo caudal. BP is well maintained so far.
So rate is also
yes,
Uh,
better,
improved.
rate is also better.
approximately
ഇവന്റെ
60.
ഏറ്റവും വലിയ കുഴപ്പം ഇപ്പോഴും പിടിച്ച് വലിക്കും.
Actually,
Wire came out.
so
Yes, yes.
definitively thrombus is a big
Enemy.
threat. That is there.
1.25, 1.5 balloon.
So LED mid segment was already, yes, mid
Bit
segment
over.
already, there was some dissection by pre-dilatation. So that wire should be manipulated very carefully.
ഈ വയർ പിടിച്ച് വലിക്കരുത് 100 പ്രാവശ്യം പറഞ്ഞിട്ടില്ല. പറഞ്ഞാൽ മനസ്സിലാവത്തില്ല.
On that segment here.
It's okay.
So it is
Level
diagonal.
is okay, man.
Yeah.
I'm okay with that. Because
that
I
is-
know that it is, that's better.
Yes, better.
Just go back to the proximal
Much-
LED is to be
Much
standard.
better.
4.8, 28 was correct size or no?
Will you will you fix the LED mid lesion?
Yeah, definitely.
Okay.
LED mid means LED proximal also there is a lesion.
Mid means not,
28 did not cover the, 28 did not cover the.
that is at the level of the distal diagonal,
It is wire,
That segment already dilated,
RF.
actually.
dilated.
Before that was dilated.
Then entire vessel should be treated.
Yes.
Entire vessel should be stented. There is no way out.
Yes,
Small check.
yes. No other option. Steel,
I'm taking this wire out. The Ramus wire I have taken out.
So ECG is okay? Dr.
Okay.
Pota? ECG is okay, yeah.
Big cranial.
There is some ready, but still STT is quite okay.
Check it.
No, this is the septal. So you have to go more distally, then you have to turn it. Yes.
yes.
Yes, that might be the entry point.
Yes,
Yes. Excellent.
yes.
Yeah. You have to
Better.
take a stent. Can you take a 48 stent? 2.548.
2.5 it is.
So that proximal LED
Will not be covered. probably.
lesion already been
Yeah, we have to cover. We have to cover.
pre-dilated.
Or
yeah?
Cover.
just that part is dilated or not?
Which stent you are taking?
Prox-
Onyx.
48.
Oh,
Color Jans.
severely fibrotic lesion.
48 to Jans.
What do you?
Jans expedition.
Alpine.
Alpine.
Pratap,
Jans
I,
expedition.
all the expedition,
Yeah.
you are taking 2.548 with the aim to cover.
No,
as
whether
well
I
as-
can take a 2.548 or what do you think? Here there is a here also people are telling I have to take 2 stents.
Yes,
Yeah,
yes.
that's why I'm,
We also like as because distally 2.5% and proximally
Little bit
3.7 to 4,
3.5, yes.
3.5 to
So
4.
you can take a 3 then, 338.
3 with.
you are considering 3 into 48
Yes.
And then take a 2.5 short stent.
short stent,
Yes,
just to cover up the
Diagonal is 3 is
diagonal
there.
level.
No. Assam actually up to diagonal there is a 3 millimeter vessel is size by OCT. So we
Yes.
can take a 3 millimeter and 38 I will take. Distal part I will take a 2.5 short stent. I don't want to take a 3 distal to the diagonal, you know.
so you will take a 2.5 a smaller stent for distal lesion.
Yeah. That's a tight disease. I think that is not well opened up.
Proximal lesion was very tight. I think
That is why-
pre-dilatation was not good enough.
Yes. The stent is stuck.
Dr. Pratap, I think that lesion need to be treated further, otherwise.
Yeah, we will take a balloon.
And that lesion might be producing more slow flow in the mid-distal LED.
Correct.
Is
Correct.
is still now very tight.
Yes.
Which balloon? 3, okay. Ramus is okay. No problem, Ramus. Circ is also okay.
Yes.
Actually, it's a very complicated anatomy.
So now it is close to 1 hour. So this is the time to check the ACT. So for any longer
I will
procedure,
do it.
especially acute coronary syndrome or CTO, you have to check the ACT every hourly. And it is wise to keep the ACT around 300.
10,
That part should be, yes.
12, 13, 40.
Or sometimes
deflate.
there is no facility of SCT, though it is not acceptable. At that moment, at that,
And the ACT should be checked,
we
deflate.
can give heparin hourly. For one initial 1 hour, then 5,000 every hour,
2, 3, 4.
Every hour,
deflate.
5,000.
5,000.
2, 3, 4.
We used to give
deflate.
2.5 thousand usually every hour.
For your kind information, due to high doses of heparin, casualty I have not seen in my life, but for low dose of heparin, meaning that forgetting giving the heparin or after 1 hour not given the heparin,
And the-
casualty has seen many times,
Yes.
many times. Though elderly, it is also high dose is risky. Even a single dose of GP2B3 inhibitor in the table due to slow flow, no flow, intracranial hemorrhage. And
If such a case of acute coronary syndrome, if the
No, no.
patient on loading of ticagrelor or praserol, you usually give.
yes.
So in this circumstance, do you suggest to give 5,000 every hourly or just
You
down
can
the dose?
just
500?
It'll take a clear stand to understand that the
GPT-3 inhibitor, the target of ACT will be 250. For without GPT-3 is 300. So that's the protocol. Then of course you check every hourly ACT and give bonuses.
on the market. Correct, go.
If the GPI in associated with the heparin, definitively ACT should be 250 is enough.
Go.
10,000.
Deflate.
Initial dose should be 10,000. 100 milligram per kg body weight
Yes,
if GP2.
75.
18. Deflate. No,
Ah,
ideal heparin given should be 70 units per kilogram is the ideal one. But in our Asian countries, people prefer to give 10,000 directly and then start the procedure. But if you go to Europe and all, they will give only 6,000 unit heparin and then check ACT all the time and then do that. So that's a strategy they follow. But I think our population is easy to accommodate the bleeding heparin. Now the BP is good. Patient is doing okay. ACT, we have checked it. Now the flow is also very good. I think as you told is correct, the proximal LAD lesion was created all the problems.
in the distal part, you will have to give a long stent, not less than
So dissection flap at the
yes.
level of the diagonal.
up to the
diagonal,
level of the diagonal.
Yeah.
only 2.5, another
It will get 2.25 or
32,
2.5 long stand under
32, yeah.
38. 38. 38 will cover. But you have to take a stent through the two stents. A 28, 428 and a 338. I have to take a long stent of 38 down.
Now you'd like to take 38, another stent, 2.5, yeah?
Yeah.
2.5.
After doing that work
Ah.
only, I have to come to the LMC and do the rest of the work.
Stenting started from proximal to distal. It is sometimes make the problem to just second or third stent delivery maybe become very much difficult. So for the juniors, better to stent started from the distal, then proximally we can proceed. In such circumstances, sometimes with so much tortuosity, long stent proximally, third stent may be difficult to deliver through the stent in stent.
I like to say for the younger colleagues, those who are going to start or those who have just started, they should always do.
I have passed the stand, the
For
stent
the
has
younger
gone down
colleagues.
easily.
Pratap, you are, yeah, we are talking about the juniors. You
I
are,
am very old. Old people cannot excuse all these things. And
Dr.
actually,
Dr. Pratap,
so
100,
you can do a lot of things.
Dr. Pratap,
So such slow flow, you have to, you have done the job very
cool.
cool
Yeah.
way. So it is not possible by all the operators.
And Dr. Pratap, you can think from there, the hundreds of our fellows are watching your case and learning from you. And that is why we are giving them tips from the beginning, how to start.
Yeah, sure. It is actually, I'm telling, my point of thinking in a different way, what I will tell you, when you put a long stent in the proximal part, if it is, you cannot track a stent like this, actually, as the professor told, the stent tracking will be a difficult job. But as age advances or experience advances, you can do that.
Yes.
But in the initial level, I also prefer to use stent in the distal part first and then proximal part. Only situation is we may lose the proximal to distal distance, you may lose the distance. I'm just telling, we may calculate the total length of 28 and 28, but sometimes when you put a 28 down, you may not be able to cover with a 28 distally. That will be one issue we may face. So you may require one more stent extra, but you should be pot. Now 4.5 balloon pot.
So what
You
about
can
the
take a
Ramas?
for-
Dr. Pratap, just can you take
My
a?
Ramus is good. I
thank
can,
you,
now we
Ramas.
can actually,
So.
we will come down and-
Stenting is
can you come to
completed
our-
now
our
to
corner?
do the post dilatation and kissing.
now the BP is very good. Patient is pain-free. ECG is settled. No problem. Now
Yeah,
this is the
excellent.
situation. Now we have to recross into the
All the
circumflex.
All the three vessels are flowing well. TIMI3 almost.
Very well. But before putting the wire, we will actually now put a wire into the circumflex. Then before that, we are going to do the next step is
Pratap,
actually
now
to
can
the
you
pot.
change your mind? Now can you change your mind with the, it is early OM or Ramas?
Probably not.
No. What I am telling is
This
actually in a RAO caudal projection.
This is a
you
bit
see if there
ambiguous
is a
situation,
Ramus.
actually. I
So it
thought
is
this
a
is
OM
the
like,
high
but-
OM, so why I thought if it is high
Actually, the
OM.
Ramus or OM is not the
Yeah.
point. What I am telling is actually in an RAO caudal projection, you look like it is a OM1, but you should go to the LAO caudal projection to see that it looks, because there is it's actually a misnomer now created. Here, people are thinking that it is originating from the, any OM vessel should originate. No, pot should be done. Give the pot below.
By
4.5.
default, any Ramas, we can consider some extent or most of the time, it may be early OM.
Either a diagonal,
But
either
this,
a Ramus or
this
either a
trifurcation,
diagonal or an OM.
Pratap, this trifurcation
Okay.
lesion seems to be allocaudal view, gives you impression trifurcation lesion, but you make a plan to down the wire in the both three branches, then you prepare the lesion accordingly by pre-drill done by the SARC and LED as well. Then you go for your procedures, but at the end of the procedures, almost you make sure, yes, it is most likely early OM, but it gives you more comfort right now because initially it gives a very discomfort situation. Actually, what should you do for go for decay crash or either down the balloon or not? But now you're sure, right? Dr. Ashok Datta, what is your opinion?
Yes, exactly.
Now the main work is to finish LM LED with LCX bifurcation. What we have done, mini crash, that chapter should be completed. Then we shall see whatever the situation of the OM. If
Yes.
necessary, even he can cross from LCX to OM.
Oh, no,
and
sir,
just
you
start
missed,
opening and given a DCB. That is
Yes,
also
sir,
option.
you-
Later on, if very much necessary.
sir, you missed the first NGOs, diagnostic NGOs, that's why. That clearly showed trifurcation
Oh.
lesion. There is a lot of discussion also there,
So,
but after preparation, the lesion, a bit.
It becomes slow down.
Slow down.
It becomes slow down.
Okay.
Whatever it is, now the
18.
prime job is to finish the
18.
half done work with.
Yeah. Still,
crash.
it is too
Exactly.
early to make comment. So Pratap, we have to wrap up the case within 5 minutes. So can you,
Oh, please. I'm
uh,
trying. Actually, I'm
you-
just doing a pot now.
you,
Go.
you try
I
to
did a
show us what is your clear message to our fellows and our audience.
Right.
You try to figure it out by your own way, how to
Yes.
give a make a message to our fellows.
Dr. Ajom, just before the procedure, he was telling me that Pratap is always unique. He tried to do each and every case by his own way, not as per the conventional way. So what is the message to our fellows, Dr. Pratap?
The message to the fellows, basically, I'm just telling you, this type of complex cases, actually, if the patient is not keen, only for CABG, then only you have to take this, ideally a case for the CABG. That's the most important thing. And if you look at this one angle, even the osteal ramus is still looking like a significant disease there. So I have to put a wire under the ramus, or it is an OM1 according to you. Then only I will proceed further because it is important. Looking like this angiogram look like LMCA look okay, LED looking okay, but after the diagonal, second diagonal, across the second diagonal, I have to do some more pre-dilatation. By the angiogram itself, then only I will. ACT is 434. I should not give any heparin now.
So what is your plan to do the PDA on the right coronary? To do it in the next
That we
setting?
will do next step only, not this today. I don't want to get a procedure, longer procedure, especially when the creatinine was 1.3 and had a contrast-induced nephropathy earlier after the angiogram itself. So
So you wiring the,
yes, pass the wire into the circumflex.
yes. So this is the
Pass the wire
Sion
into
loop
this.
or run through.
No, I always take a filled FC. That is my workhorse wire. Since I do a lot of CTOs, the only wire available in my hospital is a Filder FC is the shortest wire available. No, just put one more wire. Now I have to take a balloon into the circ. This the balloon is already, I'm taken the first balloon, 2 millimeter balloon. See, inflate, 10, deflate, just push it, just go. This is the way I do, 10, 15.
Yes.
See, this
This
is
is a
not the
good
new
technique.
balloon I have to take.
This is a good technique. Just
Actually,
once tip enters the lesion or enters the start, you will keep inflating, then pushing, inflating, ultimately that will cross.
so this is actually gone down easily now. I'll take a 3 millimeter
understand.
balloon, the same balloon I have taken earlier.
I did
The
not
three balloon.
understand, Ashok, what you have told.
So sometimes balloon is not crossing inside the lesion or through the start. Just if tip
2 millimeter
enters,
balloon.
then inflate, push, inflate like this.
That's right. For the beginner, I do not want to teach them this teach, as because sometimes there may be dissection and everything lost. But we are doing,
Yes,
many a time we are doing.
No, what I was telling Ashok, basically, I have taken a 2 millimeter balloon, just put at the ostium of the entry point, inflated. When it is deflated, I push the balloon down, easily gone down. So basically, I did not take a new balloon now. The same pre-dilatation balloon I have taken for the dilatation of the stent strut. But if there is any difficulty, then you can actually take a new balloon. Pain on 15, 18.
To re-enter into a crust stand, Dr. Pratap.
Yeah.
Dr. Pratap, to re-enter
Yeah.
into a crust stand,
3.5.
would you prefer a newer balloon or just use balloon you can
No.
also use?
No, I have taken an old balloon, but I'm telling that people can take a newer balloon. That is the best one, an easy one. And
Yes.
always when you have the crushed stent, you have to take a shorter balloon and preferably a shorter length also. And telling 6 millimeter or 8 millimeter, not a 15 millimeter balloon, because
And
the angulation will be difficult.
And dia, initial balloon.
Diameter actually 1.5 or 2 millimeter
That's-
balloon,
that's
and then the next balloon.
Progressive,
I have
Progressive,
taken
enter, yes. That is our practice.
that should be
Progressive
the
entries.
progressive.
Right. Meaning that you will require near about a half a dozen of balloons.
Yes.
This is circle. Elegant circle. Binju on the dilated. 10. Just keep it there. Actually, I had a difficulty of taking the second balloon. What I did is actually, I did a balloon inflated in the circumflex and taken. That is called angle balloon. So I have shown a technique. I don't know whether people observed or not.
So what is
Now
the
I'm
size
taking
of
the
the
balloon
kissing
back.
balloon? In the
Kissing
LCX
balloon,
it is
3 millimeter,
and in the LAD
3
it
millimeter,
is
L-
3.5 or 4?
3.5. 3.5 I have taken.
3.5
Oh.
and
Yeah.
L6 is 3.
LED is 15, 20.
So minimal overlapping should be there for perfect kissing.
10. Both 10. No, this side. Both 10.
So first you are doing the sequential,
This side.
then simultaneous.
10. Deflate together. That's the most important thing. Inflation is not the point. Deflate together always in a kissing inflation technique.
Yes, simultaneous inflation and simultaneous deflation is a must.
And I actually am telling, even if the inflation is not simultaneous,
Yes,
deflation
but
always should be simultaneous. That is
always,
the most important
otherwise,
thing.
otherwise carina will be deformed.
Yeah. Pot, one more pot, 4.5 balloon. Ramus look very good.
Excellent.
Not Ramus, all in one.
So you like to do the pot with 4 balloon or 4.5?
4.5, 4.5.
Yes, of course, that should be 4.5.
Because the vessel was flaking 4.6 in the OCT. Now after this, we'll do an OCT, diagonal LAD, and then finish it off.
Yes.
And the second pot, actually, you should keep the balloon little away from the carina. So this is the carinal part. So we have to keep it little away from the carina. No, just show the.
So this is the 4.50 into 6.
എനിക്ക് പോകണ്ടതാ വെള്ളമാണോ Okay, go 10 11 12 13 14 if now can you give me the OCT to a lady and then finish the case.
So after OCT, I think we can conclude the.
Please actually I'm sorry I kept you long there.
But actually, I am surprised how difficult case you make it simple. Pratap, how cool
No,
you
it
are.
was-
How cool you are.
Exactly.
Probably you are the happiest interventionalist and that is why you are so much so cool.
No. I actually people
Not
just tell
really,
that when I do CT,
Otherwise to remain
when I do
cool,
C-
to remain cool in such a scenario.
actually you understand that in a situation in India or Bangladesh, most of the people cannot afford this impala and all. And if it is shown from a Delhi center, they would have put an impala and make you confused. I will not use impala. And none of my cases, I never used an impala. I never used an IABP because I'm not telling that this is not bad, but I don't use these things.
My boss,
I still
Dr.
feel
So,
Shet is
the proximal LED
Use it.
stent, I think it is not post dilated with the NC balloon.
No, we have to do
I
that.
think
But I
part
just
should be
want
treated
you people are telling
appropriate
you are
further.
leaving.
Why?
after OCT you
I
will
thought
decide.
I will be. No, I will be doing that because before
Hello?
that
Hello?
you are leaving. I just wanted to show
Why?
you OCT and then do it.
OCT കാണിക്കണം, OCT കാണിക്കാൻ പറ.
Anything, just start. Ready?
Sound.
Ready.
See? Sorry,
Good.
Inject. Yes.
We got an image. I used only 10 ml of contrast. It's in the vessel oil. There is a branch there. Can you show the OCT?
So coming to the post PC OCT, three things which
Yes.
you are looking is one is expansion, second is malapposition, and third is any edge distinction. Show first the edge, any edge you can see. No, it is not possible.
So I
Then,
think
then
there
show
is-
any Renderson showed any no significant malapposition. The proximal
Yes.
here.
this is
He-
the part.
That's the
here
proximal
I'm-
part.
yeah,
That's the proximal part.
So it starts as floating actually this part.
Yes, and besides the more
Proximal part
proximity,
requires,
there is no red marking.
that part requires some post
Yes.
dilation, preferably with a 4 millimeter balloon.
No, that plot, we also thought that it would be having 4 millimeter balloon.
Then show the expansion, proximal expansion.
Yeah, 4.5 both one.
And LMC expansion seems to be good. There's no malapposition. LMC expansion almost
LMC expansion is very
good.
good. Only that mid part which we have seen by angiographically also not expanded very well.
Yes.
Can you
yes.
show that side branch opening? Whether yeah, that is free of stent studs. There's no jail stud in the side branch opening there in the circumflex. That means that the kissing balloon dilatation was adequate.
There is no strut remaining.
No
over-
studs.
Yes.
Yeah, it is.
This one
No,
strut,
no jail studs in the side branch. Yeah.
this one strut.
So except for that proximal LED, some area of malapposition, no other problem. Okay. Proximal expansion to the percentage right dual morphology.
ഞാൻ ഇവിടെ കേസ് ചെയ്യുന്ന അവിടെ നോക്കിട്ടെ 4 millimeter balloon പറയും എടുക്കാൻ പറഞ്ഞ അവിടെ നിൽക്കുകയാണ് നീ ഇവിടെ നോക്കിട്ടെ അവിടെ നോക്കിട്ടെ ഒന്ന് എക്സ്പ്ലെയിൻ ചെയ്തോണ്ടിരിക്കേ സമയങ്ങളെ can you show it?
The proximal expansion is 92% and the distal it is 86%.
Can you show the
So our aim is more than 80%. So expansion is good.
Yes.
No significant tissue protrusion.
Can you just show the bifurcation angle?
Tissue prolapse, not significant tissue.
And we
prolapse.
already shown. Yeah. Not better. That side branch opening. Side branch opening is free of jail studs that we already discussed. Only that malapposition, that proximal malapposition, that we will address with a 4 millimeter balloon.
Yes.
Edge dissection we cannot see because we didn't reach that point because there's a long LED stent.
Deflate.
And for the younger
Malapposition,
ones,
if it is more than 3 millimeter, 0.3 millimeter, that has to be addressed. Just show the malapposition, the malapposition distance.
മതിയല്ലോ വേദന മാറിയോ
How much?
we dilate with a 4 millimeter balloon in the
Yes.
Yes.
mid part of the
Yes.
arc.
it is essential.
Just can you
0.7,
0.7.
0.8 is
4
the-
millimeter balloon, we
yeah.
went up to 15
Much.
and
Yes.
can you show? This will be the last shot. Arroyo caudal, one shot and finish it off.
For the younger
give
ones, always see very meticulously the TIMI flow whenever you place 2-3 stents or meaning that entire vessel is stented. Usually there may be, here it is TIMI 3 flows, all right, but sometimes there is, there
Different.
occurs TIMI impairment.
So thank you very much. I think it is
Excellent
nicely
result.
expanded stent everywhere.
And
Pratap, thank
Dr.
you
Pratap.
very much for your great case. I must say congratulations for your brilliant case. We should give a big hand for him, Pratap.
Thank you, Dr.
Thank you.
Pratap. On behalf of Bangladesh Society of Cardiovascular Intervention, we congratulate you and hope that you will be in the midst of us in the next upcoming meeting. Thank you.